Hi, everyone. So now we're going to start the second part of our gram-negative bacilli lecture for our medical microbiology for medical students series. So we just talked about enterobacteriales. Now we're going to talk about non-fermenters. In parentheses, I put, AKA not enterobacteriales, because that's really where the name non-fermenters comes from. Enterobacteriales in general ferment glucose, and the list here in general does not. I don't think you need to know any more details than that. I think it's a waste of your time to understand how we do these fermentation tests and stuff. Just if you're questioning why do we group all these things together, it's really just our easy way of saying things that are not enterobacteriales. The most common one is Pseudomonas. Pseudomonas aeruginosa is the main species of non-fermenter that we are concerned about from a medical point of view, and she is not our friend. Pseudomonas aeruginosa is not very common, but when you see it, it does cause all the same sorts of infections that E. coli and Proteus enterobacter can. It can cause urinary tract infections. It can cause wound infections. It can cause pneumonia, all these sorts of things. However, Pseudomonas aeruginosa has a very different epidemiology compared to enterobacteriales. So when we talked about things like E. coli, they are normal parts of everyday flora. Most people walking around in the community have E. coli in their gut. Pseudomonas aeruginosa is not like that. Pseudomonas and its cousins actually live in the environment, especially associated with soil, with plants, with water. So they're kind of used to living in these weird nutrient-deprived environments. And because of that, for whatever reason, they also have this ability to really live in the hospital. In the hospital, there's often, like water in drains, things get contaminated with patient specimens. We clean them to try and get rid of typical bacteria like E. coli. But for some reason, there's these organisms like Pseudomonas aeruginosa that are able to persist in these hospital environments. And when they are in the hospital environments, if you have a patient that's been in the hospital for days or weeks or even months, then it gets attached to their plastic, it gets on their hospital bed, and it ends up inside the patient themselves. So even though Pseudomonas is not really a quote unquote normal part of the human flora, in patients that have been in the hospital, especially if they've gotten antibiotics to kill off some of the more normal stuff like E. coli, we do see Pseudomonas getting in those patients and then causing these infections. So again, for your otherwise healthy, young woman coming in with a bladder infection, Pseudomonas is really not on my radar as something that would be causing that. But if you have an elderly patient who was in the hospital for a hip fracture, and then a week after their surgery, they have signs of a kidney infection, I actually would be worried that some Pseudomonas might have gotten in their body and into their gut and overtaken their normal flora. And then over the course of time, it is able to cause the same sorts of disease that E. coli can cause when it gets into the wrong place, like the bladder or surgical wounds or central lines. So that's Pseudomonas. Pseudomonas is a good one to start with because she has a bunch of sisters that all do very similar things. So Acinetobacter is another one that is not our friend. Acinetobacter is especially common in ICU type of environments. We actually don't see it that much in Canada just because it's not in our environment as much, but it can cause all the same sorts of things that Pseudomonas does. And again, we only tend to see it in patients that have had extensive hospital and antibiotic exposures. Stenotrophomonas is another one that is very similar to Acinetobacter, but I've given it this kind of like meh face because she is not quite as nasty as Pseudomonas and Acinetobacter. Stenotrophomonas is really more happy in the environment than it is inside the human body. So when it gets onto, for example, ICU patients, sometimes it just isn't quite as virulent as something like Pseudomonas. It's not uncommon for us to take sputum samples from patients that are intubated in the ICU and find a little bit of Stenotrophomonas, even in patients that don't have any pneumonia, just because the Stenotrophomonas is happy to sit in the plastic of their breathing tube, but not necessarily actually go in the lung and cause disease. So I'm not saying Stenotrophomonas can't cause disease. It certainly can, but it's not quite as virulent as some of the other organisms like Pseudo or Acinetobacter. And again, just to really emphasize, these are organisms that we are not typically seeing in healthy hosts. These are more hospital-associated, antibiotic-associated organisms that develop over time in these more vulnerable patients. And of course, there's all their friends, which is like this humongous laundry list of different bacteria. We've got non-aeruginosa Pseudomonas, which there's too many for me to list here. Burkholderia, Achromobacter. I'm not going to waste my time to read all of these out. But essentially, these are all organisms that fill similar niche to Pseudomonas and Acinetobacter and Stenotrophomonas, which is that you do find them in soil, on plants, with water. And it's only in very particular situations that you can see that they have gotten into a patient and maybe they're causing disease, maybe they're not. You'll really have to put your thinking caps on. So these are not typical pathogens. In fact, in my mind, I kind of organize them like this, where like Pseudomonas is really number one. If there is a single non-fermenter you need to be concerned about, it is Pseudomonas aeruginosa. Acinetobacter is number two. It is also a virulent organism, but we just don't see it as much as Pseudo. Seno is less than that because it's not that common except in these like ICU patients with heavy antibiotic exposures, and it also doesn't cause as much disease as commonly. And then all their friends are even smaller than that because, I can count on my hands how many times I've seen patients that are actually truly infected with Pseudomonas that isn't aeruginosa, for example. Certainly, if you swab, the plants in your garden, you'll find these things. But if you actually swab a patient, I don't know if these are going to be causing disease. One small exception is Burkholderia in the case of cystic fibrosis. Cystic fibrosis lungs pathophysiologically are just so different from otherwise healthy human lungs in regards to their protein contents, their immune system, the way that bacteria form biofilms and interact with each other. So Burkholderia is one that I think is useful to memorize, causes actually quite severe disease in cystic fibrosis patients. But other than that, if you find Burkholderia in just your run-of-the-mill patient, you have to really think about it in terms of its causing disease. So those are the non-fermenters. Before we move on to our next group of bacteria, I want to just take a few minutes to talk about antibiotics a little bit. This isn't a talk specifically about antibiotics, but I do want to discuss this question. What does it mean to choose antibiotics with good, quote unquote, gram-negative coverage? My answer to this is like, it's really hard to tell. And as a medical student, I always found this very confusing because it's a very context-dependent question. This is something where doctors throw out this phrase all the time, oh, we need better gram-negative coverage for this patient, let's change the antibiotics. But to me, as a microbiologist and someone that does infectious disease work, I really have to think like, what are the typical organisms we're actually talking about for this patient? And what are the local resistance patterns? So if we talk about like a run-of-the-mill E. coli that, someone in the community with a bladder infection would have, there's lots of antibiotics we can use to treat that. We would expect things like ampicillin and ceftriaxone and levofloxacin and etc. to all have some activity for your run-of-the-mill E. coli. So if we want gram-negative coverage for E. coli, we really, in general, have a lot of choices. However, some of these E. coli, Klebsiella proteus organisms can have a little bit of resistance just because there's lots of antibiotic exposures around. So, you might have a patient who had an E. coli bladder infection and then later had a Kleb pneumoniae bladder infection, but the Kleb pneumo was AMP resistant and Ceftra resistant and levofloxacin resistant, but the rest of them worked, right? So here, this would be an example where levofloxacin would not be great gram-negative coverage for this particular patient because they've got a Klebsiella pneumoniae that it just happens to be resistant for. So you've still got lots of options, but something like levofloxacin, etc., isn't 100% guaranteed to have good gram-negative coverage. This gets even more complicated as we talk about our further organisms like Enterobacter cloacae, where these can actually have at baseline very high levels of resistance to broad antibiotics like ceftriaxone and ceftazidime, where we might only be left with a couple of different antibiotics. This is an example where if you had a patient who has a history of these 3 different bacteria with these particular susceptibility profiles, the only antibiotic that's actually on this list that would work for all 3 of these isolates is meropenem, right? This is something that you really have to think about in a case-by-case basis, because in general, I would say, oh, ceftriaxone is pretty good for covering, Enterobacterales, but in this particular patient, maybe not. This gets even more complicated if you want to cover Pseudomonas, because you can see that this patient's Pseudomonas has resistance to almost everything except for ceftazidime. I think some doctors get confused and think, oh, meropenem is in general a broader antibiotic than ceftazidime, so it must always be better for all bacteria. But that's not the case. We see Pseudomonas aeruginosa all the time that is susceptible to ceftazidime and resistant to meropenem. So really what I'm just trying to demonstrate here to you, I don't want you to memorize any of this. I'm just trying to tell you that when you're talking about good gram-negative coverage, like you can't just say that and then just let it sit there and hope the magic antibiotic falls into your lap. Like you really have to think about which specific bacteria am I trying to cover, and is there local resistance patterns that I have to be aware of? For example, when people talk about gram-negative coverage, to be honest, they're normally talking about these organisms, Enterobacterales and Pseudomonas aeruginosa. They're almost never talking about Stenotrophomonas. And the reason is because all the antibiotics we love for E. coli and Pseudomonas, like ceftazidime and meropenem, and often fluoroquinolones, have a tendency to not work very well on Stenotrophomonas. So again, like it's such a funny question to me when it's like, how do we get better gram-negative coverage? When in my mind, it's a totally different question if you're talking about E. coli versus Stenotrophomonas. So again, I know this is kind of a high-level discussion, but I just wanted to introduce this to you so that when you're on the boards and thinking about gram-negative bacilli and choosing antibiotics, you can understand that it is a bit complicated, and you don't need to feel bad if it's hard to apply your learning in pre-clerkship into clerkship just because of the diversity of clinical presentations and antibiotic resistances we see with gram-negative bacilli. So on that complicated note, that brings us to the end of this second section of our gram-negative bacilli lecture. We do have a third shorter section after this, so we will see you there.